Assistant Director of Provider Education for the Association of Community Cancer Centers, or ACCC. I'm eager to introduce Ali McBride, our expert presenter for the second e-course of the series hosted by the Institute for Clinical Immuno-Oncology, or ICLIO, who will discuss the role of a specialty pharmacy in managing immuno-oncology access, costs, and patient expectations. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by immunotherapies and includes other vital resources such as our newsletters, papers, our scholars program, a national conference which will be held September 30th in Philadelphia. So please visit www.accc-iclio.org to browse all of our offerings. Now for today's e-course, I'm pleased to introduce Ali McBride, who's Clinical Coordinator of Hematology Oncology at the University of Arizona Cancer Center. He also currently serves as the Association of Community Cancer Centers Board of Trustees, and he's been actively involved with the American Society of Health System Pharmacists, the Arizona Pharmacy Association, and the Hematology Oncology Pharmacy Association, for which he serves as chair of the Legislative Affairs Committee. He received his BS degree in neurobiology and physiology from Purdue and an MS in biology from Indiana University, Purdue University, and then his PharmD degree from the University of Arizona College of Pharmacy. And for a few housekeeping notes, please feel free to submit questions to our presenter by typing in the box on your dashboard. Questions will be posed to Ali McBride at the end of his presentation. And we will be archiving the webinar and we'll make it available on the ICLIO website by the end of the week. Now I'll send it over to Ali McBride to kick off our webinar.
Well, thank you so much for the introduction. And again, welcome everyone to the actual discussion today. Our topic talk for today's webinar will be really addressing ICLIO and its role in newly developed immunotherapies. So our objective, just to start off, will be to understand the role of specialty pharmacy in immuno-oncology through real-world examples. So really what's happening in our clinics, in our hospitals, and also looking through our reimbursement profiles as well. So just to actually top off our four pieces, we'll be addressing first access, costs, and reimbursement issues that may arise. We'll then look at some discussion topics in regards to pathways and formulary management, which may be a very interesting discussion as we see more and more immunotherapies come up with different indications and also different drug therapies being approved. Just recently we had one approved yesterday as well, so we're seeing this continually arise in our current market. We'll then touch upon managing patient expectations, really addressing some patient pivotal issues as well as addressing patient concerns or things that may occur in clinic while on therapy. And lastly, we'll just be touching upon additional considerations and challenges which can occur with immuno-oncology. Next. So just really to get everything started, just to address specialty pharmacy, when we look at specialty pharmacy, this general overview gives us a really brief understanding, a generalized understanding of specialty pharmacy at its briefest point. So specialty pharmacy refers to the distribution and handling of specialty drugs and biologics. So when we look at specialty pharma or pharmacy, it includes that drugs that have high complexity, and these are generally non-oral or non-oral administered drugs, biologics that are injectable, and that can treat complex medical conditions. They're complex in nature, complex in design, and they're also biologic molecules which are usually distributed through infusion or injectable formulations. We also have drugs which are considered high touch, and these are drugs or biologics that require specific types of distribution. In these cases, it can include, for example, special storage and handling, administration for therapies, also patient management. In addition, these therapies can also require special clinical training for administration, also follow-up. And lastly, when we kind of categorize specialty pharmacy, we can also put these pieces into high-cost drug therapies. And these are all often considered drugs or biologics that fall under specialty pharmacy, which can be very expensive, upwards of almost $400,000 per year in some cases. It's generally reimbursed through Medicare Part B, and although it can be covered in the pharmacy benefit as well, depending on the actual drug therapy. Next. So really looking at examples of immuno-oncology, they actually fall under the specialty pharmacy category. Now, just for looking at this, you see this is actually already an outdated slide, so I'll actually make that caveat up front. We currently have had several different types of immuno-oncology or immunotherapies being approved in the past. We often think about ipilimumab many years ago being approved for unresectable or metastatic melanoma, and also just recently in the adjuvant setting for the treatment of melanoma. This was actually one of our first immunotherapies that we utilized in the course for treatment, and one of the first to come about, almost a landmark clinical trial that actually had that drug approved. When we take a look at other immuno-oncologies or other immunotherapies, we can also see that other therapies have arisen since that first introduction of IPI. Nivo actually coming about for its approval. In this case, nivolumab is approved for unresectable or metastatic melanoma, metastatic non-small cell lung cancer, renal cell carcinoma, and just recently approved again. The expectation here is to get some paucity before I announce it, but last week it was approved for Hodgkin's lymphoma as well. So we already see a fourth indication for nivolumab in this setting when we're seeing numerous amounts of actual indications coming about. Just with nivolumab approval, we have seen already 4 indications. We expect more in the future. The same thing with pembrolizumab. Currently it's indicated for unresectable or metastatic melanoma as well as metastatic non-small cell lung cancer. So again, these 2 therapies for the PD-1 inhibitors have actually shown, again, looking at a multitude of indications, we only expect more from these 2 as time ensues. We'd also recently seen the approval of Flimagene just late last year, and this is also a drug therapy which is used as an actual subcutaneous administration, vaccine therapy for melanoma. And this is for unresectable cutaneous or subcutaneous nodal lesions in melanoma recurrent after initial surgery. And so this actual vaccine is a recombinant-based vaccine therapy and is used on these patients in which they get injections for these in-transit lesions in melanoma. And again, showing the fact that this example of immunotherapy coming on board is showing efficacy in different disease states, but also different types of mechanisms of actions as immuno-oncology continues to develop over these last few years. Another therapy which is often not talked about, but that's Sipuleucel-T, which is actually a vaccination, almost a vaccination, not truly a vaccination, but it's utilization of one's own cells to actually develop an immune response in the setting of metastatic castrate-resistant prostate cancer. And we have seen that also being used the last few years as well. Now, recently, there was another PD-L1 just approved yesterday, and excuse my New York accent as I kind of rolled that out there for those people who know me from New York. But essentially, the just recent approval just came out from FDA yesterday in regards to the utilization of a PD-L1 therapy. It's the first PD-L1 therapy coming about, and that was just approved for bladder cancer called urethral carcinoma. So it's the first one approved in this setting. So we're already seeing this market come about rather quickly and be developed rather quickly as we're kind of paving the road for immunotherapy over this next decade or so, with a number of indications and also a number of therapies going into this marketplace. And really, just to end up, there's 5 to 6 additional indications which are expected for immunotherapies in the next year or 2. And just talking about this and just how quickly it's occurring, this slide's already outdated by at least 2 indications here. So we're moving ahead rather quickly and at a fastidious pace in terms of where we're looking at in the future with immunotherapy. Next. And when we take a look at the potential scope of indications with immuno-oncology, we're looking at different disease state indications. And here's just an example of the current pieces of the pie that are being looked at. And again, it's not to name all of them, we just kind of listed a few. So melanoma is where we've already seen several indications with immunotherapy in the immuno-oncology setting. Non-small cell lung cancer, again, based on the drug therapy, also looking at the PD-L1 expression, the actual therapies are indicated there as well. Renal cell carcinoma, just a recent indication just a few months ago being approved. Hodgkin's lymphoma just last week. And I should have pulled out, but again, as my slide decks were submitted and revamped, bladder cancer just came out. So that's also a piece of the puzzle, which does have an indication right now. looking at numerous indications for this disease setting in both some of the liquid tumors, but also majority of the solid tumors, including head and neck cancer and also myeloma, just to name a few, as there are other trials with different indications as well that are coming about, being developed right now. So this is a vast area for therapies, and we really need to be very cautious about how we're treating these patients. So looking at one drug therapy to the next, looking at one disease state to the next, we're seeing a multitude of pieces of information, clinical trial data, and also both management of these drug therapies in the pharmacy, managing these therapies in the clinic, and also addressment of patients who are currently on these therapies to make sure they can continue on these therapies because of side effect or side effect management protocols. Next. And really, here's an example of when we're looking at specialty pharmacy, kind of meeting the two together in immuno-oncology. So there's often a lot of roles in immuno-oncology that can include, but are not limited to, the following areas. Access and reimbursement, a key pivotal piece in understanding immuno-oncology, because unfortunately, if you're not getting reimbursed for these drug therapies, which are sometimes high cost for institutions and also patients, you really have to address these access and reimbursement issues up front, working with your financial team. And luckily at the University of Arizona Cancer Center, I have a great financial team which I work with. I work with Wendy Andrews, and she does a fantastic job with her staff, really looking at this and addressing this with pharmacy to make sure patients are getting great access with financial counselors, and also looking at reimbursement profiles on the back end as well. The second piece is pathway and formulary management. In these things, we're looking at actual pathway integration and also formulary management from the institution. Now, pathway management can occur either through a payer-based model system, or it can occur through institutional-based pathways, which may be dependent on certain situations with contractors or payers as well. So we have both of these pieces of the puzzle actually being addressed, and that's the key point for the treatment for these patients. And also institutionalizing these pathways and formulary management become key access points for continued therapy. And lastly, the next piece is managing patient expectations, so really addressing the patient profiles for these patients to make sure the patient is aware of their current therapy and making sure they understand the therapy at that point, side effect profile management, and also continued treatment cycles with therapy while they're on immuno-oncology therapies for their disease state. Next. So when we take a look at specialty pharmacy and immuno-oncology setting, we look at access and reimbursement. So again, just a very simple piece here, trying to break down the puzzle for access and reimbursement, because oftentimes it's much more difficult for clinics and institutions. But looking at just a brief overview, looking at specialty pharmacy and oncology pharmacists, their main focus for a lot of these disease state pieces with immuno-oncology therapies is managing inventory, making sure those are on par for patients coming in. Looking at distribution lists, how is that drug coming in? Is it coming in next day? Is it drop shipped? Is there a par level in which you actually have a certain amount of your inventory in which that gets restocked and reordered when you actually hit that number? And also dispensing immunotherapies, making sure healthcare professionals, nurses, nursing staff, and advanced practitioners are aware of these dispensations and how they're given, just to make sure it's in a consistent basis across the overall workflow with these therapies. Immunotherapies such as Nivo and Pembro can be cost prohibitive for patients, and this is actually especially true for combination immunotherapies such as nivolumab and ipilimumab. And again, making sure the key piece here is going to be addressed is how these patients are getting access to these therapies. So just for example, with our staff here at the University of Arizona, the oncology clinical pharmacists actually work with the finance staff in a one-on-one setting, and they also address these therapies up front. So we have a fantastic collaboration with our finance, our financial counselors, our nursing staff and physicians, such to the fact that as soon as these therapies come on board, the clinical pharmacists are aware, they contact the financial counselors. So up front, those patients can get some of the paperwork done to address utilization of these therapies to make sure they can get patient assistance developed. Also look at any formulary issues that may occur with prior authorization, and also we'll be discussing a little bit later on, but off-label discussions as well. So we try to do a lot of this work up front to make sure the patient has access. And just for example, with Nivo and Ipi, that we actually always do patient assistance for these therapies to make sure the patients meet some criteria where copay assistance or other assistance can be provided to those patients. And lastly, the oncology and pharmacists actually ensure proper on-label use, so we actually make sure those patients who are getting on-label actually have on-label use. That's actually coordinated with our finance department as well. And in regards to off-label use, the oncology pharmacist or clinical pharmacist in oncology will work with actually public, either Medicaid or private insurance payers for approval and reimbursement, and that all goes through a workflow process with our financial counselors. So don't think that the oncology pharmacist is doing everything. There's a lot of the legwork is done with our financial staff and financial counselors here at the Arizona Cancer Center. So we give a lot of credit to them to really get those patients going through therapy, starting therapy on time, and really we're dependent on them, and they do such a great job. So having that collaboration early on with our financial staff, as well as correlating it with our nursing staff and our physicians, has really provided a much better workflow, almost a seamless workflow at times, to get these patients on treatment early on during the actual discussions for patients rather than actually waiting around for continued discussions on treatment therapies. Next. So looking at our current immunotherapy clinics and managing immunotherapy in clinics, really just to give you a simple workflow, our oncology clinical pharmacists are working in the clinic with physicians and our providers to actually address on-label and off-label access. So just in our cases, in our settings, we actually have the pharmacist working in that setting with the nurse there and also the physicians in the clinic, really addressing those financial access points up front. So if there's an off-label discussion while they're there, the actual pharmacist will discuss it with the physician, make sure that they know the actual therapy is off-label. And this way the off-label therapies are interpreted with the physician teams to actually address current data. So is there data for the utilization with those off-label therapies? Is there phase 1, phase 2 data sets that can be provided to insurance up front? The data in the chemotherapy order is documented with an off-label reference. We actually have built that into our computer system, which I'll go over a few more slides, with the actual guideline recommendations. So if you're using NCCN or other compendia for evaluation for treatment, that is provided in that documentation setting in the actual chemotherapy treatment plan in our electronic healthcare record. And also our finance and our financial counselors are immediately contacted. So as soon as that drug therapy, in this case, is off-label, or even on-label, we actually make finance aware and our financial counselors aware as well. In case any paperwork needs to be filed, we can get that done rather quickly, or at least provide the patient with information they need to actually give back to us so we can continue to actually address that medication patient assistance program. In addition, the pharmacy is made aware of the process for inventory control management if there's a free drug piece coming aboard in those situations. So if we're looking to actually have free drug replacement or drug replacement, the actual pharmacy has to be made aware so they know that drug is coming, and therefore once that drug gets inventoried, we have our inventory control chain already provided and are documented as well in Epic for treatment with that free drug. Next. And looking at specialty pharmacy immuno-oncology, there's other considerations to really address for access and reimbursement. The 340B drug program, again, for those who are DISH hospitals, these are discounts on drugs and biologics from manufacturers given to the hospital and other covered entities. On average, discount can be about 22.5% of ASP. For those institutions, they have to be eligible for the 340B program. The hospital must have a minimum disproportionate share percentage based on the share of the hospital's inpatients who are Medicaid or low-income Medicare patients. And this is actually based on the report to Congress for the overview of the 340B drug pricing program. And Medicare and other insurers will reimburse the same amount for Part B drugs to 340B participating institutions and non-340B hospitals, just to give you a brief overview. Other areas where you have to worry about evaluation for reimbursement as well as contracting, and based on your institution and based on your hospital site or clinic, hospitals and payers will negotiate contracts really to manage costs, and these will be managed care which provides a significant percentage of revenue for a hospital, ensuring patient access to treatment and services, and also provide access to managed care products and pilot products that can actually increase revenue for the hospital. So looking at risk sharing, maybe value-based benefit designs as we're talking or continuing to talk about these managed care-based development or share programs as well. In addition, for contracting based institution or the clinic site, Also making sure you have good formulary management. We have key component pieces here for specific formulary management in the inpatient setting and also some in the outpatient setting as well. And also looking at some preferred drug use, prior authorizations as well as other areas where managed use can actually be developed. And also making sure we have a more efficient distribution model is going to be important when you're actually developing contracting channels, depending on what drugs you're looking for indication, your overall utilization, or number for utilizations in those disease states as well. Next. So looking at the next step, which is pathway and formulary management. So for us, oncology pharmacists are actively involved in deciding which drugs and biologics are placed in hospital formularies, and pharmacists are integral members of the institutional P&T, pharmacy and therapeutics committees as well. So they're actually bringing key points along with the physicians and providers, as well as other risk management staff and key personnel in the reimbursement setting. In addition to formularies, many hospitals and institutions utilize pathways, which are either developed within the institution or are provided by third-party organizations. And these pathways are decision support tools which are used to establish the actual clinical guidelines. So almost like following an NCCN guideline pattern pathway or development pathway by those actual third parties, utilizing literature to actually determine the most effective, least toxic, and least costly therapies for a particular tumor type. And these all vary, and they can actually find different pieces of this based on your own institution. Sometimes you may also have your own actually algorithm for treatment cycles as well and supportive care measures, but this is actually based on the formulary management. So we don't have a lot of these. We do have a few of these for our own institutional pathways, but we're dealing most of this from payer-based pathway discussions coming from insurance companies where we're actually looking at starting a patient on therapy. And really the overall viewpoint is oncology clinical pharmacists are integral in deciding which immunotherapies utilized in the institution. They actually become a key part of this. Our clinical pharmacists here at the University of Arizona do a great job really addressing those patients and also working with our current institution, our physicians, and our team members to address these key questions when they do arise in clinic for those patients who are eligible or may be eligible for therapies for continued care. Next. In addition, just a brief overview for pathway and formulary management. When we talked about those outside organizations for pathways, there are different types. Again, there's VIA Oncology, AVITA. There's also McKesson and also US Oncology value pathways, which are utilized and powered by NCCN, and New Century Health. And there can be other ones as well. There may also be other ones which are institutional-based, which people have utilized for their own institution-based practice settings for how they actually develop treatment patterns. And that may also go again with other sites which may have clinical trials as well. So these pathways are not all-inclusive, but just to give you an understanding of how these pathways are being developed, how they may affect your clinical practice, and also how you may have to address these issues in regards to specialty pharmacy based on what you're purchasing and also what you're administering for our patient populations. Next. And so this is an actual, it's okay. So sorry about that, everyone. So looking at integration of therapies for P&T consideration, just looking at the University of Arizona Cancer Center, when we actually have a formulary decision-making process, it actually varies from inpatient to outpatient, but the whole goal is to integrate the oncology service line. So we utilize this decision-making for formulary process based on the utilization indications, and we also look at this based on electronic medical record indication. So we integrate a lot of our chemotherapy based on the treatment and how we're going to be utilizing these therapies, because once it's approved or once it's going through the formulary decision-making process, it then has to be built into the EHR record for patients, and then also the chemotherapy treatment cycle needs to be built out along with it as well. So it's a long process, not as easy as it was with paper, but it's a dependent process for how those drugs are put in formulary. And there may be variations between your inpatient and outpatient setting with some looseness, and that means that in regards to indications on how you're able to use outpatient treatment in that setting. The extent of which pathways are utilized in UICC can include institutional-based formulary, and pathways are based on payer pathways for treatment. Again, this is actually coming from how they're being utilized, and also if you're utilizing pathways from third parties. So are you going to be utilizing this prior authorization process, and then those depictions for what you treat with next can occur from the actual insurance. So there can be some variation between your institution and also pathways from third-party payers. Pathways from payers or third-party pathways being developed for payers that you have to address with your current treatment for chemotherapy. If you're using more therapies, which actually have variants, that we have to actually discuss with in regards to your payer and also your finance team, as well as institution. But again, these may vary on a case-by-case basis. So for the case study, how insurance companies are starting to utilize pathways for preferred treatments and how that may affect utilization within the actual University of Arizona Cancer Center, it's really getting the actual right therapy to patients. So, if we have a patient who may be clearly an indicated treatment with an immunotherapy in this setting, we can say, for example, melanoma, we can actually take a look at their pathway. Perfect case is, in some cases, we had patients who had actual autoimmune diseases, and we wanted to start them on ipilimumab. We usually like to start them on ipilimumab. We had to actually go through some process pathways because in regards to pathways from the insurance, they would actually institute IPI first on these certain patients. However, because the patient had an autoimmune disease and you don't want to exacerbate the actual issue with the patient for IPI-based utilization, we would actually go to pembrolizumab in those cases, or Nivo. So we actually would bypass that IPI. We had to process that, and we had actually gotten that first case done before we processed it, and we actually had a pathway for utilization going around the actual pathway because of that patient population who we do see with autoimmune diseases who cannot tolerate IPI. Next. And really the last part, and the biggest part, is really managing patient expectations. So, we have a great example here of patient financial resources. So as mentioned before, immunotherapies are expensive and can be a financial burden to patients. One of the things that we do have, luckily in our clinics, is the oncology pharmacist can actually assist the patients by providing resources and programs that can help the patients pay for these therapies. And this is really alongside the information coming from the financial counselors and also our finance team. And really with the oncology clinical pharmacists, they can provide education regarding finance and other resources, and also manage and enroll patients in patient assistance programs or assist in finding alternative or financial or advocacy-based programs. So we work alongside a lot of our team members with the financial pieces being enrolled. The financial counselors do a fantastic job on doing this, and the clinical pharmacists in the actual oncology clinics are really helping them address this. And this goes both for the different types of formulations when we're looking at, for example, intravenous or oral therapies. There's variations in how they can be looked at and addressed, and so we play a key integral part of that team to really address those patient pieces. And really the financial counselors working with the actual clinical pharmacists have really helped the patients get access to these therapies early on for continued and initial support during the actual start of their chemotherapy. Next. In addition, one of the actual key pieces the clinical pharmacist can play is medication therapy management. So immunotherapy actually stimulates an innate response against tumor cells. As a result, patients can experience immune-related adverse events. Here we have the acronym IRAES. And again, I won't pronounce that as one word ever again, but I'll just say immune-related adverse events. So in this setting, oncology pharmacists will actually work with the multidisciplinary teams, physicians, nurses, advanced practitioners, to really address and manage the actual adverse events through supportive care, lab testing, looking at drug therapies in these cases, to really make sure we can actually continue these patients on treatment, but also manage their actual side effect profiles while immunotherapy. As part of the multidisciplinary team, the oncology pharmacists play an integral role in patient adherence, probably one of the key pieces of the puzzle these days for continued therapy and actual outcomes. So really by forming a relationship with the patient, educating the patient on possible adverse events, and also providing any necessary tools and resources to help keep the patient on their immunotherapy. Next. And one of the actual things that we have the clinical pharmacists work on is the fact that we're looking at the incorporation of patient assistance programs into patient workflow. So how do we actually have that develop into institutional workflow when we're actually starting a patient on therapy? So here's a typical example. Again, every institution is different, and we may have some variances at your site versus our site, or at other larger sites or smaller sites, depending on the actual number of patients starting immunotherapy. But here's our example. So we can have a patient who we're looking at for off-label immuno-oncology therapy based on the current indications and clinical data. So they may actually have some clinical data available, some phase 2 studies, but the drug's not approved in that indication as of yet. The content for the chemotherapy is entered into our electronic healthcare record. Supporting data is included in the actual record, as well as the reason for treatment and recommendation guidelines. So we use our compendia guidelines here as well. Everything is entered into our chemotherapy or our Beacon treatment plan. And then the finance team then works on a prioritization for the patient. And actually the clinical pharmacist addresses that. I just skipped a beat there, so excuse me. And they address the content with the finance team. The financial counselors will then address content for the patient assistance with the patient. So really getting a workflow in there from A to Z as best you can once you're starting this process. The finance team then works on the patient prior authorization. They address pathways if those are a concern. Again, the finance team will actually work on this with the pharmacist if needed, really working on the addressment of issues that may occur with the actual pathway discussions. They'll also address insurance content for approval. Financial counsel at the same time will address copay assistance for the patients. If there's a potential drug replacement or free drug therapy, that will also be instituted, and also the pharmacies involved with this as well, making sure they're aware of the drugs coming in. And we'll address approval for start dates. So sometimes it may take several weeks to get that drug in the hands of the pharmacy to start the patient. So really making sure everyone's updated. The pharmacy where the drug is being compounded and administered from will actually be made aware of the free drug replacement, so everyone again is on the same page. And charge codes may be changed for administration, therefore not billed to the patient. So here's a typical just type of schema. Every site will be different, but I do recommend that you have that in place, or at least an algorithm or workflow model in place for these patients who are actually undergoing these off-label treatment workflows. Next. And when you're taking a look at the electronic healthcare record and electronic medical record, so for those people who are always typing in electronic healthcare record in Word, I actually tend to use EMR because as soon as I type in EHR, it goes to HER, unfortunately, so I have to type out electronic healthcare record almost every single time and still add the EHR to the Word document profile as well. So here we actually have a number of different circles, and if you look at them directly focused and you cross-eye yourself, you'll probably lose vision. But again, here we have 5 typical examples of what we tend to do with the electronic healthcare record. The first piece is document and track patient care electronically. So our clinical pharmacists are there in the actual clinic working with our team of physicians and providers, looking at diagnosis stage, tumor pathology, as well as other issues including adverse events, some toxicities, lab results, and interventions that may occur on there as well. They can also evaluate the health history, medical history, and also current medications, looking at issues that may occur or may be occurring while on therapy or at the start of therapy, utilizing the incorporation of evidence-based guidelines and pathways, and formulary-based discussions with the electronic healthcare record, documenting, which we currently do, patient's progression, treatment, or maintenance while on therapy at this point for either new or continued treatment with immuno-oncology therapies. Also communicating between the multidisciplinary team, the cancer team, making sure everyone's aware of issues that may occur. And lastly, appropriate billing and codes, which can be utilized, especially with the advent and startup of the ICD-10 codes, which we're currently utilizing in our EHR record, which is Epic at this point. Next. So looking at the EHR and also EMR in these cases, well, there's a lot of advantages and disadvantages. I think we all know the disadvantages, but I think with the integration of a lot of these electronic healthcare records, the advantages are far outweighing the disadvantages. First, we have the means to create data sets or data points. So you can track sequencing of therapies, outcomes, and also cost-delivered care, especially with the current treatment process that we use with Epic. This is actually very seamless. The data can be pulled rather easily once you build those reports. Consistencies through integrated guidelines, pathways, and also formulary can also be implemented in these cases as well, making sure it's consistency across the board. Improved efficiencies and cost savings can also be evaluated for these patients, and also other process implementation pieces you can utilize. Communication between departments and with patients, and again, this is actually based on your own electronic healthcare record, but this information can be seamless and also be utilized very often with a patient rather than actually working on phone calls or discussing other issues. There's a lot of direct patient interaction here as well as lab results. It allows participation in national programs, value-based programs, and also pilot programs. And just some examples of electronic healthcare records: Epic, Cerner, Sunrise, iKnowMed, Elekta, and Mosaic, just a few to name in regards to the current healthcare, but we're seeing more and more dominance towards the former two, Epic and Cerner, as we're seeing these process changes across electronic healthcare record sites. Excuse me. So disadvantages and also challenges, well, that's also the biggest issue. So integration between departments, between other hospitals using different systems. In some cases, we can have patient information between different networks not communicate. We use Epic, so in other sites, if they allow us, we can actually see their notes from other sites utilizing Epic. It's a great advantage for patients and also for healthcare teams rather than getting a 2,000-page fax. Training of all members in the multidisciplinary team can also be a disadvantage because some cases the electronic healthcare record looks different for each team participating in electronic healthcare record evaluation or viewpoint. The electronic pieces need to have reliable backup for storage as well. And sometimes incorrect data can actually be integrated into the actual patient care, and it can actually propagate throughout the entire electronic healthcare record system as well. So everyone is different, but everything can actually be visualized in different advantages and also disadvantages, or pros and cons in these situations. And we have seen this continually develop, and also we are seeing these pieces for updates develop quicker than what we're used to at this point in time. So there's a lot of things going on with electronic healthcare records. As you build it, it will come as probably the best or most apropos discussion point on that. Next. Integration of EMR workflow with oncology. Again, the University of Arizona uses Epic as our primary EHR. We use Beacon for our chemotherapy templates. Some of the actual great pieces that have developed from this was consolidated pathways for supportive care measures. So we've actually created pathways for current, for example, CNIV protocols and also other protocols for disease treatments, as well as, for example, immunizations and a few other points as well. It had a maximized reporting structure for chemotherapy. So we actually have current disease state treatments, so we can pull that information as well for what's being used. We also have the ability to track dose changes, which is going to be updated with some of the USP 800 discussions. And also, we document in the Beacon treatment plan the off-label pieces. So we actually have that built into our treatment plans, and we can actually report that to P&T, which we currently do, and evaluate that with our finance team to see what's paid for in some of these CMS cases as well. In addition, we can actually document drug waste for billing as well, which we do here, and that also we can take advantage of that, as well as if you're using a rounding policy, that may not be the case for drug waste. So in this case, if you're doing that and you don't have drug waste, again, having a good policy for drug rounding is important as well. In addition, it provides improved care for outcome measurements in cancer care. So transitions of care, I think one of the biggest issues right now, going from an inpatient setting to outpatient setting, it really has improved that transition of care issue when we're seeing those patients come outpatient. In addition, oral chemotherapy is a very large issue. So currently we're actually treating patients with oral chemotherapy. We have our specialty pharmacy actually document notes for the patients for adherence profile outcomes when they're picking up drug therapies, and also letting the clinical pharmacist know in clinic if there's any issues occurring or financial issues that need to be reviewed within the physician team site. In addition, financial approvals, patient assistant notification, that's also documented in our actual Epic notes. So when patients come in the day before, the clinical pharmacist will work to make sure the patient is approved for therapy, and therefore prevent any patients from not coming in, and really try to increase satisfaction scores from that period as well. In addition, we can actually document drug replacement programs, so the pharmacy is aware that when the patient comes in, if the actual drug infusion is approved for, that drug will come from the drug replacement stock that may not be there. Lastly, the patient treatment workflow. It's a key integral piece if patients are being seen in clinic, making sure, for example, questions arise about dosing, chemotherapy. Those pieces are actually documented in the chemotherapy treatment plan. So all team members, whether they're actually in the infusion site, the nursing site, the nurse is actually infusing it, the pharmacy or physician team, everyone's on the same workflow pattern. So a lot of key concepts were developed with the oncology EMR workflow. So these are just a few of the settings that we have actually included based on how we treat a patient in this setting. Next. Some other areas, just kind of going through the topic for specialty pharmacy, is actually some additional considerations. Of course, we have seen the recent data in regards to managing drug waste, the billions lost with drug waste based on the content piece pulled from Sloan Kettering, where they actually look at dose documentation for drug waste issues. And managing drug waste is a large concern, a looming concern, especially in specialty pharmacy, because of the high cost of these immunotherapies. So for those billing for waste, it becomes a key piece. How do you do the rebilling based on the dose afterwards? Making sure you have that in your workflow is essential. Now, the other piece for that is if you're running an actual dose rounding policy where you don't have to bill for drug waste, you're actually rounding to the vial size, that also helps out as well. But making sure you have one of those two right now as soon as you start with immunotherapies is going to be critical, because if you don't have that there, you will probably lose hundreds of thousands of dollars in drug waste if you're doing a large site with immuno-oncology clinics. So making sure you're aware of that, and also addressing that by bringing it back to your P&T, or making sure you're actually evaluating what's the ROI on your managing drug waste policy. You know, you need to actually look at your ROI for this content as well to make sure everyone's on board. So making sure that dashboard for managing drug waste or rounding is always on there, because you want to make sure you can report that information to some of your other team members and also higher-ups in the organization. In addition, other areas of distribution is white bagging or brown bagging, and if you ever heard Bonnie Kirschbaum discuss this, it's a very good discussion point. So really, white bagging can result in loss of storage space for hospitals who are forced to store biologics not purchased by the hospital. So really what's happening here is you actually have therapies being sent directly to the hospital to be infused. And so in these cases, you can have lost revenue as a result of the no buy and bill model. And often what happens in these white bagging, we tend to use this for a lot of our free drug replacement. Your space or storage space will actually shrivel up rather quickly, because as you have more and more free drug, you're going to have to use or store that with spacing areas, and that can become a burdensome site for a pharmacy that's already compacted. Brown bagging can result in compromised drug or biologic integrity, since it's actually the patient's responsibility to store it. So in these cases, again, I'm not doing justice to Bonnie on this one, but brown bagging, a patient gets a drug and they bring it in to be actually compounded in the facility, and based on your state pharmacy laws, this may not be allowed, because again, there may be fidelity issues in regards to this, as well as any track and trace-based policies as well for administration. And lastly, preventative or duplicative efforts within the specialty pharmacy may also occur. So making sure you actually have a workflow based on this. You want to make sure you have the best patient management out there in regards to the multidisciplinary team to make sure these patients, or when they're getting the drug, there's a workflow set up in this process. Next. So really, in summary, specialty pharmacy and oncology pharmacists actually play an essential role as part of the multidisciplinary team in immuno-oncology that manages the following: access and reimbursement, including issues we talked about for ensuring drugs and biologics in the hospital, clinic, or center, distribution and dispensing, and also reimbursement costs. One of the key essential pieces is for pathway and formulary management, as we talked about before for the P&T committee. And lastly, managing patient expectations, another key part where education coming from a multidisciplinary source really allows the oncology clinical pharmacist to really address issues beforehand and while on therapy for the patient. And a majority of those issues can be addressed through adherence and side effect management, including the immune-related adverse events. In addition, tools such as the electronic healthcare record and EMR are integral components of specialty pharmacy, improving total patient care within hospitals, clinics, and centers. Next. So I'm sure no one has any questions at this point in time.
Ron, we have quite a few questions that have come in. So again, thank you. That was a great presentation. And so I will pose some questions now. So one of our audience members asked, knowing Medicare does not have a prior authorization process, how does your institution's financial and clinical pharmacy provide a determination for off-label use in the Medicare population?
That's a great question, and probably the most important piece of the puzzle, right? Because for whoever asked that question, that's probably the biggest question looming out there, and it's the toughest question to address, because just like with anything with CMS, you can pretty much give anything under a CMS-based contract. It doesn't mean you're going to get paid for it. So in this setting, what we tend to do is we try to evaluate the content. If it's not compendia-based, we are not going to give it unless we can get free drug replacement for those patients. So that's our current workflow for these situations with the immuno-oncology setting, because when we take a look at some of the information coming out, you can just have a phase 1 study which is being sent off of, but you may lose that money. So we sign the patient up for patient assistance. We also look at free drug replacement in those things as well to get that patient moving forward. And if the data is not there, the only thing that we can actually resource to would be the free drug replacement, because you don't want to be scorned for actually providing care to the patient, but at the same time you want to make sure you're following compendia-based guidelines to make sure we can continue treatment or start treatment for that patient. So excellent question. I think that's probably the biggest question that does pop up when we're looking at all these new indications coming up. Even though the drug's approved, these indications are becoming more and more numerous in the clinical setting. And with recent data coming out, or new abstracts, or phase 1 studies, you know, we tend to see a lot of jumping on the issue to get new patients on therapies which may not be indicated for at this time. So to me, I think that's the best question. You get the gold prize for question of the day. So thank you again for that question.
Great. And also, you know, you alluded to earlier about immunotherapy being very cost prohibitive, especially used in combination. Can you go into detail about how your institution goes about providing access to combination therapy?
So we tend not to use combination therapy unless indicated or unless clinical trials are there. Actually, I continue to give kudos. We have a great financial team here led by a manager, Wendy Andrews, who runs this process. And so what our team works with the financial team is really addressing, you know, what's the data for this? So, you know, where does this data come from for combination therapies? And in this setting, we try to make sure that the combination therapies, when given, are being addressed appropriately and correctly. Now, there's some combination therapies in which everyone goes through patient assistance. That's the NIVO and IPI program, and also the adjuvant IPI as well, to make sure those patients are going to get looked at for free drug or patient assistance in case there's a denial. And we have made sure everyone is upfront with that. So really our clinical pharmacists who work in melanoma, they're addressing the issue upfront with our patient population, and then they continue therapy on that from there. In some cases, when we're looking at a lot of the off-labels, we may not be able to get the actual drug approved, so the only way to get that drug for the patient and not to have it off-label is to make sure we can get free drug for that patient. So that, again, going back to that white bagging discussion, which we kind of ended on in regards to our discussion with these therapies, is becoming a much more pivotal point. And really, that free drug replacement program really decreases the burden or risk on us when we're taking a look at these combination therapies that may be seen in the literature in early phase 1 or phase 2 clinical studies as abstract forms, but not have the phase 2 data yet, or hasn't matured fully yet for approval or utilization.
Okay, great, thank you. And another question, so how do you integrate a patient's EMR information from an out-of-network hospital or institution into your center's EMR?
So that's what we do, and that's a good question. Now that question I'm just going to answer in regard to the chemotherapy treatment. What our clinical pharmacists will do is when they're in clinic, the oncology pharmacist will work with the physician, our nurse, and advanced practitioners. They'll take a look at the current chemo, and if the chemo has been utilized in the past and they're switching to another therapy, that won't be integrated into the treatment plans, but it will be integrated into the note, and that will actually be documented by the treating physician. In other cases where the patient is continued on treatment, say for example we have a patient started on 1 cycle of therapy and they actually transition to us for cycle 2 or 3 of therapy, the pharmacist will actually put that initial cycle that will be documented to be given at the outside hospital, which we can do with Epic rather easily, and also provide any dose adjustments or changes that were made if there are actually deviations from the actual basic protocol for treatment. And they'll continue on with that for their current treatment cycle at our current institution if they're actually continuing therapy here. So that is documented to some extent in the actual, not only electronic healthcare record in the note, but also we're able to document, you know, moving from cycle 1 to cycle 2 based on how we're building it out in our Epic beacon-based protocol for treatment plans. And I think another piece, I was going to say one more piece in that one, which I forgot to tag on to that, is if you're using Epic, one of the key features is you can pull Epic notes, if allowable by the patient, from another site using Epic, so you don't have to actually go through all those notes. So there is a lot of that data. Labs are in there too, which can be utilized from other sites when they're on the same Epic framework.
Great. Well, thank you. All right. Looks like we might have time for one last question. Looks like, all right. Looks like certain 340B health systems own their own specialty pharmacy and market that outside their system to other organizations. Does this enable the health system to further leverage the 340B discount outside of their system?
So I really can't answer that because we don't do that with our pharmacy, our specialty pharmacy here. So that's not really something I could address at this point in regards to how they're leveraging 340B. But again, if you're running 340B, just a basic point, you can only treat patients who are actually, you can only utilize 340B for physicians or providers who are at your site. So for those patients who are under 340B, those are site-based patients under the dish. However, if they're being treated from another physician, getting that specialty drug therapy, they're getting at the WAC-based cost. So there is a difference, and that inventory needs to be maintained. It's a compliance issue in the 340B management discussion.
Right. Well, thank you so much. Don't want to take up any more of everyone's day and their time. So again, thank you, Ali, for the engaging presentation, and thank you so much to our audience for participating today. Both the webinar and the slides will be available on our website, and again, that's www.accc-iclio.org, and we hope to have those up by the end of the week. And also, as a registrant, you will receive an email with the link, so please feel free to share that with your colleagues who may have missed the webinar today. And I also hope you'll register for our next webinar, which is coming up on June 1st at 1 p.m. And that'll tackle the issue of immuno-oncology policies. And our presenter is going to be Dan Todd. And last but not least, don't forget to save the date for ICLIO conference, which is held on September 30th. And we'll have a lot of engaging real-life conversations like the one we had today. So thank you so much, Dr. McBride, and thank you to our audience.
Thank you, everyone, again. Have a great rest of the week.